It is now my pleasure to turn today's program over to Sue Strant, Director of Patient Engagement for Arthritis Foundation. The floor is yours.
Thank you, and hello. My name is Sue Strant, and I'm the Director of Patient Engagement at the Arthritis Foundation. The purpose of today's webinar is to share some osteoarthritis, or OA, information with you and to understand what your experiences have been with OA. Today's discussion will focus on how osteoarthritis affects your life, what your experiences are with treatments for your OA, and what your thoughts are on the potential for new treatments. The presentation will include preliminary results of polling questions that most of you completed during registration for the webinar and a conversation with two physicians. We here at the Arthritis Foundation thank you for registering to participate in this webinar and for completing the poll during registration. Your volunteering spirit and your dedication are integral to our success as we work together as a national community to find a cure for OA. Thanks in large part to the Army of Arthritis Advocates who worked tirelessly for more than 2 years, the Arthritis Foundation celebrates the signing of the 21st Century Cures Act, a landmark bill that will accelerate medical research and the approval of drugs and devices by leveraging innovation, technology, and most importantly, patient input. The Arthritis Foundation is optimistic about the bill's impact on incorporating the voice of the patient in drug development, and this webinar is one of a series of events the Arthritis Foundation is convening in the spirit of this bill. Now it is my pleasure to introduce my colleague, Dr. Amanda Niskar, the Arthritis Foundation National Scientific Director. I want to thank Dr. Niskar for her leadership in this important project and for inviting me here today to be a part of this exciting work. Before Dr. Niskar shares the preliminary polling results, we would also like to thank our planning committee for their critical role in developing the polling questions. Our committee was comprised of patient experts as well as scientific and clinical experts. Dr. Niskar will now share the preliminary polling results.
Thank you, Sue. I appreciate this opportunity to share preliminary poll results with all of you today. The results I'm presenting are preliminary and for the purposes of discussion only. I'll begin by describing a few characteristics about the population who responded to the poll. This poll was conducted January 6th to 25th this year. 311 people completed this poll from a total of 45 states. 298 people responded yes to the question, have you ever been told by a doctor or other health professional that you have osteoarthritis? As I continue to present the results today, I will refer to osteoarthritis as OA. Among respondents who said yes to having OA, 90% of the respondents were female. This might be attributed in part to the fact that osteoarthritis in general affects more women than men. However, OA affects both men and women with differences based on the joint involved, age group, and other factors. 67% of respondents were over 60 years of age, but this poll does demonstrate that OA also affects young adults and middle-aged adults as well, with 8% of respondents being aged 31 to 50 and 25% aged 51 to 60. 20% of respondents reported a recent diagnosis of less than 5 years, and 65% of respondents reported a family history of OA, while 23% reported that their OA is associated with a previous injury or trauma. Now let's move on to learn what you told us about the most significant impact of the OA on your daily lives. 89% of respondents reported that pain and tenderness are the most significant sign and symptom impacting daily life, while 74% reported stiffness was their significant sign or symptom, and 71% reported walking and standing limitations. These same 3 signs and symptoms were reported to be the top 3 signs and symptoms not being satisfactorily addressed by past or current therapies. To treat these signs and symptoms, the past or current non-drug therapies most tried by respondents were physical therapy, vitamins, and exercise. FDA-approved drug therapies most tried by respondents were acetaminophen, also known as Tylenol, over-the-counter non-steroidal anti-inflammatory drugs, and steroid injections. When poll participants were asked about which outcomes are most meaningful to them, 75% selected stopping current pain tenderness, 73% chose preventing pain tenderness progression, and 72% reported ability to walk. These meaningful outcomes are important to inform drug research and development so that we have new OA drugs in the marketplace that give patients the results that they want. When considering taking a new treatment, the top 3 factors that respondents selected as most influencing their decision to choose treatments are that the treatment is effective for the specific benefit most meaningful to you, that they have access to the treatment including insurance and cost, and that the possibility of a rare but serious side effect might exist. These preliminary data will be reported as part of the discussion during the March 8, 2017 Arthritis Foundation Osteoarthritis Patient-Focused Drug Development Meeting. Detailed results of this poll will be included in the Voice of the Osteoarthritis Patient Report to be submitted to the FDA in September 2017. The report will be available to the public on the Arthritis Foundation website. The report will be a tool to help accelerate drug research and development, resulting in faster, cheaper, more effective clinical trials so that we have new OA drugs in the marketplace that give patients the results that they want.
Thank you, Amanda, for presenting our preliminary patient voice results. Next, I am pleased to introduce 2 special guests. Dr. Virginia Byers-Kraus is Professor of Medicine, Pathology, and Orthopedic Surgery and a faculty member of the Duke Molecular Physiology Institute at the Duke University School of Medicine. She is a practicing rheumatologist. Dr. Kraus is also past president of the Osteoarthritis Research Society International, or ORSI. Dr. Christian Latterman is a professor of orthopedic surgery at the University of Kentucky Department of Orthopedic Surgery and Sports Medicine. He is a practicing orthopedic surgeon. Dr. Latterman was named as one of the 16 standout North American sports knee surgeons by Orthopedics This Week, the most widely read publication in the orthopedics industry. If you are participating via webinar and you would like to know more about either of our guests, their full bios are available by clicking on their photos on the webinar console. Dr. Kraus and Dr. Latterman will be discussing frequently asked questions about scientific discovery and the prevention, diagnosis, and treatment of osteoarthritis. When their discussion is completed, we will open up the chat feature for webinar participants to have the opportunity to ask questions. I will now turn it over to Drs. Kraus and Latterman.
Good day, this is Virginia Kraus. Thank all of you for joining us. Dr. Latterman, it is a pleasure as always to speak with you today. As an orthopedic surgeon and a scientist, could you please elaborate for us on your specific area of focus?
Yeah, hello, good afternoon, everybody, and hello, Virginia. It's always fantastic to have this opportunity. My particular focus of practice is originally coming out of the field of cartilage repair and joint restoration as a sports surgeon. And over the last decade, I have more and more moved into the treatment field of early osteoarthritis prevention and diagnosis, with pretty much the goal to help develop and study novel treatment approaches for early osteoarthritis and cartilage injuries, which are very much interconnected. And as such, I practice in that space between sports injury, post-traumatic osteoarthritis, and established osteoarthritis.
What message is the patient's voice to you in your experience preventing, diagnosing, and treating OA and post-traumatic OA?
Well, generally, I often find that there's a lot of frustration over several areas. The first thing is that usually comes to me is that as a tertiary referral center, I do not necessarily see the patients first time out. I see them after they have usually failed other treatment options and they're being told that there's no other possibilities. So the frustration of a lack of adequate treatment options short of a knee replacement is very high. Another question that I often get is, why is it me? I'm so young, I really haven't done anything bad to my joints. Why do I get this? And that often requires explanations as to, what the background for their particular form of osteoarthritis is. There's also a great uncertainty about what this really means for the future of their activity level, of their overall life engagement possibilities. And then another question that I get, and which I want to close with, is what could they have done differently, or can they do anything differently now that will either slow this progression down, or what could they have done to prevent it in the first place?
Sure. As physician scientists, I think you and I both have spoken at length about how we share the frustration of patients, and have been really gratified to see that the Arthritis Foundation has been removing roadblocks, and sometimes we call it taking the boulder out of the path of OA clinical trials that might provide new therapies for OA. I was wondering if you might address a bit from your experience what some of these challenges are, these boulders, and how you see the Arthritis Foundation scientific strategy playing a role in removing these boulders.
Yeah, so in order to answer that question, I have to go a little bit back for the audience to understand where we see these boulders. The biggest problem with osteoarthritis is that it is a little bit of a silent killer to a joint, if you want so. So it's very difficult to actually see when this process starts. And the only currently approved tool, really, that, for example, is the base for any research that the FDA was accepting is an X-ray. X-rays are notoriously late in picking up osteoarthritis changes. So in other words, if you see these changes on an X-ray, it's usually almost too late to really do anything about it. We have to come in much earlier. And the big boulder is that we do have technologies to pick this up earlier, but they are not officially accepted. And that's the biggest boulder that we have, because we have to wait technically until X-rays turn positive, and that is too late for most of them. So these rather, at this point, probably you can call them antiquated outcome measures, and at the same time, a lack of hardcore scientific evidence that newer technologies can really replace this, that has been a big, big problem. And the Arthritis Foundation has started several years ago to really move this boulder out of the way by supporting research to improve the scientific evidence for newer technologies, and by reiterating that the X-ray as an outcome measure is antiquated. It has been really committed to removing this boulder, and in fact, actually, they were instrumental in putting together the first groups to really talk with the FDA directly about how we can remove these roadblocks. And I think that is the one of the most important developments in the last few years, and has already moved us into a couple of clinical trials that are now testing newer technologies that will hopefully soon allow us to treat this disease at a much earlier time point.
So it sounds like what you're describing, patients may have a reason to be excited about the future of scientific discovery. Is that true?
I do believe so. Yes, I mean there's 3 or 4 major developments that happened in the last 5-6 years since I was part of this effort. One thing is that we have learned to actually incorporate several different aspects of what we call outcome measures into judging whether our therapies are working and what our patients want. That include things like patient-reported outcomes. In other words, basically, what does a patient themselves really feel when we treat them with conservative measures or with operative measures? But also, improved functional measures. We can now actually measure specifically function that we can then relay back to objective or also subjective outcomes of patients, things like strengths, things like gait, and those kind of things can be measured. We also have made great strides in defining so-called biomarkers. Those are essentially blood tests or urine tests or tests from synovial fluid that we can do that allow us to determine how far advanced the osteoarthritis is, how severe the overall osteoarthritis is, and it allows us to measure our treatment successes. Now, there's still a lot of work to be done, but these are very exciting newer technologies that we currently have available that we are currently studying. And if I look at this is a light year away from where we were about 10 years ago.
I think I really share your optimism as well, and in particular, just wanted to highlight the issue of the involvement of the FDA and the ability of the Arthritis Foundation to link all of us together, the researchers, the patients, with the FDA in order to help move this field together.
Yeah, I cannot agree more with that. And I think the key here is, and this is why I am particularly excited about working with in this field and with the Arthritis Foundation, is that they have understood that this is really a team effort that is required here, and that includes everybody on the table. That includes the FDA, that includes the patients, that includes the Arthritis Foundation, that includes physicians like you and I. And I think this is one of the very few areas where I truly feel that this engagement has come to fruition, and I think that is very exciting, not only for the patient but also for me as a physician.
How do you think that people with osteoarthritis, their family and friends, can play a role in expanding these treatment options for OA?
There's several ways. I think the most important thing is advocacy. Osteoarthritis has, even though it is very common and everybody knows about it and everybody has somebody in their family that has osteoarthritis, it is still not one of the recognized top 10 diseases. So advocacy is important, and the Arthritis Foundation has made great strides towards that. And it needs to just basically show up on the forefront. It is probably never as dramatic as some other more life-threatening diseases, but it has a significant effect on your daily life, as most of our patients certainly know. In addition to that, I think they can engage on a more local or regional level, for example, through the Arthritis Foundation or other organizations, to help other patients deal with the disease. Osteoarthritis is a disease. This is not just something that breaks and you can fix it. It's a disease like diabetes or like high blood pressure. It needs to be continuously treated, and it needs tender, loving care. Very
well said. And may I just add that the poll itself provides a voice that is much needed in this entire process and is linked in. And so I think you will share this, that we're both very excited about the prospect of getting this information and having this large link from patients, families, the Arthritis Foundation, the FDA, and us as physician scientists.
I think there is no question, and in fact, Virginia, you know that just as I do, you write grant proposals to federal agencies. In fact, this is now a requirement for a researcher like us to have a connection back to the patients, and we are actually required to produce data along those lines. So by doing polls like that, you're actually actively supporting the research effort.
That's great. What do you view as success? What would your success look like 10 years from now?
So if I can answer that really quickly, my best success will be if I was out of business in 10 years from now. However, whether we are going to achieve that or not, I don't know. My wife would probably like that. However, I do believe from a slightly scaled down perspective, I think anything that we can do to move the treatment of osteoarthritis into a evidence-based, effective treatment approach, have effective treatment protocols that are fairly standardized, and that allow us to start treating this disease when it happens, which means at a very early time point when the knees initially get injured, for example, after sports injuries or so, when we know that this post-traumatic osteoarthritis starts, and ideally we don't have to battle regulatory agencies, insurance companies, etc., about definitions of whether this is or is not osteoarthritis. As a matter of fact, it is, and the semantics need to go out of the way. If we can achieve that in the next 10 years, then I'll be very happy.
Thank you so much for your thoughtful insights.
Thank you. It's always a pleasure.
And thank you so much to our special guests for such an insightful and honest discussion. Now we're going to open up the chat feature for webinar participants to have the opportunity to ask questions.
And as a reminder, if you would like to ask a question via the web, click the green Q&A icon on the lower left-hand corner of your screen, type your question in the open area, and click Submit.
Thank you so much, and we actually already have several questions, so we'll get started right away. The first question is, what percentage of people with osteoarthritis also have rheumatoid arthritis?
I guess as a rheumatologist, this is Virginia, I'll be happy to try to answer that. There is a very unfortunate few individuals who have both. It can occur, but of those with osteoarthritis, it is far and away less than 1%. It's a very small number. Usually these things are independent of one another, but they can affect some individuals who have both.
Great, thank you so much. Our next question is about stem cells. Can you comment on the role of stem cell transplants in the treatment of knee osteoarthritis?
Yeah, I think I can probably answer to that. So the short answer to that is we are simply not there yet. The longer answer is there is a lot of clinical trials that are being done currently to utilize either stem cells or other bodily derived pluripotent cells to treat knee osteoarthritis. There's in the U.S., one trial has been recently published, which is a randomized clinical trial that showed some very minimal effect of it. The biggest problem here is that the hurdle is pretty high due to the fact that in any of these randomized clinical trials, the placebo effect is actually fairly significant, and none of these trials that have been published so far really have been able to overcome that. What does that mean? It doesn't currently look like the stem cell injections really are a lot better than what we currently have available. However, it doesn't mean that they don't work. It means they are working as well, which could offer an additional opportunity for treatment. However, the problem is in the overall drug regulatory process, the regulatory agencies want to see a better effect than a placebo or a concurrent treatment, and this is where the difficulty comes in. There's still a lot more work that needs to be done. I think it is something that is real, but currently I would only really recommend that in form of a randomized clinical trial, because everything else is truly unproven.
Thank you so much for explaining that. This next question is asked by someone who's particularly interested in interventions that are not drugs or medication. The question is, what is being done to replace cartilage or synovial fluid and worn discs in those of us with severe degeneration, particularly in the neck?
I guess that's a question that also I should address to a certain degree. So generally I can tell you that in the neck specifically, there is very, very, very little that's been done. There is some work that's been done in general for disc degeneration. However, that is also quite a bit behind what we are doing in the larger joints, such as the knee joint. There is no synovial fluid in the neck, unless you are talking about the very small neck joints, which can also have osteoarthritis, of course, but they are so small that you cannot replace them individually. What you would have to do is you would have to actually fuse the neck, which is what is currently being done by most orthopedic spine surgeons in light of severe neck degeneration. There is a possibility to do guided injections directly into those small joints in the neck, where you can actually do the same thing that we do in the knee, where you inject a little bit cortisone into it. But however, that has to be done under so-called fluoroscopic guidance, which means that is under X-ray control, and that needs to be done by a specialist.
I'll just add to that very nicely described current state. We are hoping that new treatments for hand, hip, and knee osteoarthritis might benefit the spine. But we still have a long way to go to really understand all the causes of spine OA. Certainly genetics play a big role, and the genetics of spine osteoarthritis seem to be some overlap with the genetics of hand osteoarthritis. So our hope is that the treatments in general for osteoarthritis will benefit the spine, but that really remains to be seen.
Thank you so much to both of you. Our next question is about clinical trials. Are there currently any clinical trials focused on stopping progression of disease, or are they mostly focused on stopping pain?
I can start by answering that. Traditionally, most of the trials had focused on pain, and for that reason, we are privileged to have some fairly good pain relievers, both as nonsteroidals and various opioids, which we try to use as sparingly as possible. The real challenge, however, is to try to get at the root causes of the disease, and but if one only focuses on, say, an X-ray or an MRI, one is ignoring the important aspects that we've been talking about all morning, which is how a person actually functions, what their quality of life is, pain and tenderness, all the things that the poll showed were of most importance to people. So it's really been a challenge to really strike both of these in a way that's shown true efficacy. So one recent study trying to develop biomarkers for osteoarthritis has actually used as the outcome looking at the combination of worsening of pain symptoms and worsening of X-ray, and referring to that as clinically relevant progression, and trying to develop biomarkers that pick that up so that then we can use that, those biomarkers as tools to find drugs that will slow clinically relevant progression defined as worsening symptoms and worsening X-rays, so that we could really strike at the heart of the disease as opposed to mask the symptoms, which is, of course, of benefit to relieve symptoms. But ultimately, we would really like to relieve symptoms by striking at the heart of the disease. So this is in the forefront of everyone's thinking and really where we're going in the future.
I think this is a beautiful answer to the question. The one thing that I may add is, in order for a clinical trial to be focused on stopping the progression, the key issue is when does the progression actually begin and where does it stop? And in the past, we have learned that once you have fully established osteoarthritis that is basically at the end stages radiographically, we know that at that point it is too late. And so, we have started to work at the very beginning of this, basically right after traumatic joint injury. And here we are still in the infancy, but we are starting to see some very early changes in those joints that we now have to correlate with very sensitive MRI measurements to see if there's truly already structural changes that happen that early that we can pick up earlier. And then that will open the door to future trials, which we are currently already talking about, on actually stopping the progression of this. But this is something which is why I'm excited over the next 5 to 10 years, because I think within the next 5 to 10 years we'll see these kind of trials, and then they are more than just trying to be a pain treatment.
Thank you both. That is exciting to contemplate what lies ahead. We have another stem cell question, this time really looking at stem cell therapy specifically as an effective option instead of surgery. Could one of you comment on that?
Yeah, I think I want to answer that because I kind of sort of made that statement about the stem cells beforehand. I think these are two different issues. Stem cell therapy cannot do away with surgery when it's needed. It may be able to delay surgery, but it is not likely going to be effective in lieu of surgery, because surgery really comes into play typically at an end stage of the disease. And I have very strong doubts, everything that I've seen about stem cell therapy, that they can undo damage that is already done to the degree that a surgery is completely not necessary. It will hopefully help be another weapon in our arsenal to delay the inevitable, but I doubt that it is able to completely reverse the progression of osteoarthritis, everything that I've seen so far.
Thank you for that. That sounds like a really important distinction. Our next question comes from someone who is navigating both type 1 diabetes and osteoarthritis. And the question is, what are the options to treat OA given that steroid injections can raise blood sugars?
This is Virginia. That it can be quite challenging, and in addition to diabetes, there are many other conditions that people with osteoarthritis suffer that make it a challenge to treat with the current treatments. Of greatest importance and at the core of all of the osteoarthritis treatment guidelines is exercise and good nutrition, weight control, and all of those seem to be beneficial for all types of osteoarthritis, and in addition benefit diabetes. So a very safe bet without adverse effects of drugs would be appropriate exercise. That said, it can also be very challenging for people with osteoarthritis to get into an exercise program because sometimes they do too much or for too long and will suffer side effects and be unable then to continue on or feel that the side effects really make it too difficult. So it's important to have an appropriate advisor as to how much, and typically we'll also recommend that water aerobics is a great place to start because you only weigh 1/8 in the pool what you weigh on land. So you can get a lot of movement of your joints and good cardiovascular exercise without the excess strain on the joints. So that's a good place to start, but it's still good to start under the guidance of a physical therapist who really can taper the guidelines and the exercise to you as an individual and ramp you up slowly. The key is slowly. And that really is one of the safest ways really to treat both the diabetes and the osteoarthritis.
Great, thank you so much. The next question is about pain and why pain is intermittent. And the person asking cites that weather changes seem to impact pain, but beyond weather change, why is pain intermittent?
I'll be happy to answer that. I find this to be a very fascinating question. There was a study in the 50s or so in the UK that looked at that, and then there were some more recent studies in the last decade in the U.S. that looked at that study. And what we know is that, interestingly, inside your joint, the body maintains a vacuum, so that helps to keep the joint feeling stable. When the barometric pressure changes, the pressure inside the joint is affected, and people will oftentimes act as their own weather predictor and say, my joints are telling me that the weather is going to change, and there seems to be some evidence for that, and that the change in the pressure inside the joint can produce pain. In addition, of course, the intermittent pain comes and goes, can very oftentimes be triggered by excess activity. If the joint is unstable, then if it gets moved out of sort of normal alignment, it undergoes large stresses and strains that produce all kinds of biological effects. So we're well aware that this intermittent pain is related to movement, activity, excessive activity, and there are different qualities and types of pain that we're beginning better to understand. So what the questioner has brought up here is something that's very valid for people.
Yeah, one other aspect of that is, and this is something that I see a lot coming more from the sports world with younger people who have OA. Occasionally, there can also be a mechanical reason for that, particularly if you have a loose body in the joint or you have a truly loose piece of your meniscus that can get incarcerated while you're moving it. That can lead to very temporary, very severe pain that then gets better as it kind of clicks out of the way. In those few cases, this is actually something where an arthroscopic surgery can help. It will not help with the generalized osteoarthritis pain, and it will not stop the osteoarthritis, but if it is truly mechanically caused spot pain, if you want so, that is something that can sometimes be addressed fairly successfully.
Great, thank you so much. We have a few questions now about imaging studies. Primarily, what would be preferable to x-rays in terms of diagnosing OA, and what would something like an ultrasound reveal if you suspected osteoarthritis?
Well, we have been trying to develop MRI technologies to pick up osteoarthritis earlier and earlier. They're different, unlike x-rays that can only show what's happening in the bones. It cannot show anything about the cartilage or the tendons. They're invisible on an x-ray. The MRI can see the bones, the cartilage, the meniscus, the tendons, the fluid inside the joint, the lining of the joint where inflammation occurs. And so it gives a holistic picture. And there are many, many different kinds of MRI, some which can actually show very, very early changes, and others that can show accumulation of water and swelling in the joint. So real experts in this have developed to a very fine science the types of MRIs that could give us the best indications of inflammation and early OA changes. So the field has been moving to try to standardize those and validate those so that they could be accepted as outcomes in trials by the FDA. Ultrasound is a marvelous technique that is particularly good at picking up changes of inflammation, which can occur in osteoarthritis very frequently, but you cannot see by eye as clearly or overtly as you can, say, by looking at someone who has rheumatoid arthritis in their joints. Nevertheless, it's there. The problem with the ultrasound is that it's not available for use by experts. In other words, to get good ultrasound pictures, you really have to have an expert in ultrasound who knows how to position the probe just so so that they could interpret the image. More and more people are getting trained, and the American College of Rheumatology has a training program for people to gain that expertise. But it's not as widely available. It's much more dependent upon the imager, as opposed to MRI, where you can set the instrument up, lie down in the instrument, have the knee, and then let the instrument do its magic, and you get the pictures that can be interpreted pretty widely.
If I may add to that, the MRI and the ultrasound technology, I think, also has a couple of other issues. The first thing that I think is really important, and this is still something that we are wrestling with, is we should not completely dismiss plain X-rays, of course, because they are a very helpful tool as an initial screening tool. However, the problem is that they need to be done correctly, and there's very standardized ways how these can be set up, and that is something that we are still trying to implement to this day. Regarding the ultrasound, it also has a therapeutic component to it, because under ultrasound you can do very targeted injections where you assure that whatever you are injecting, if this is something like viscosupplementation, which is that the rooster cartilage kind of substance that is supposed to lubricate your joints better, or steroid injections, they can be targeted directly into the joint, and you can see that it's actually getting into the correct spot. Because occasionally you can have misinjections, which are then very painful. You can avoid these under ultrasound.
Thank you so much for walking through all of those different imaging options. We're going to change focus a little bit with the next question to look really at causation. The question is, how close are we to understanding what happens at a cellular level post-injury that increases the risk of OA development?
Virginia, do you want to start on that?
Feel free. Since we both work on this, I think we're waiting for the other one to give their insights. Please.
So I'll give you the less cell biological answer to that. So that is indeed a question that we've been asking ourselves, and Dr. Krause and myself, we've just recently completed a clinical trial where we wanted to know what exactly happens early after an ACL injury, which is that's the classic model right now, probably the most well-established model, where we know when an initial injury happens, and that will most likely, in a large percentage of patients, lead to osteoarthritis down the road. And what we found is that when you tear your ACL, within the first 4 weeks of injury, your articular cartilage will already show changes that are consistent with the beginning of osteoarthritis. You will have a depletion of certain proteins out of the cartilage that indicate loss of substance of the articular cartilage. You also have a significant inflammatory response that happens. And some of that may be cell mediated. Why do we believe that? Is because we actually did try to intervene, and we found that a simple injection with triamcinolone acetonide, which is a form of a steroid injection, will actually alter those findings. And that may have an effect particularly on one particular cell type inside the synovial lining. There's a lot more that we need to find out about it, but there is very, very early changes that happen here, and it is not so that the articular cartilage just basically, goes by unshaved. When you have joint injuries of a nature of a ligament tear, there's more that happens. And from a more specific cell biological standpoint, I'll let Virginia kind of elaborate a little bit more on that.
Yeah, I like to refer to joint injury as the heart attack of the joint, and remind people that when I was a resident in training, the treatment for a heart attack was to put people at bed rest for 6 weeks. And no doubt, as the participants are fully aware, nowadays people get straight into cardiac rehabilitation right away. and there are all kinds of therapies to dissolve the clots and put in stents. And so it's treated emergently and to prevent downstream problems. I think we're facing the same paradigm now with joint injury. From what Dr. Latterman was just describing, we're gaining insights that tell us that the immediate weeks after a joint injury are really critical to joint health long term. And we think perhaps if we can alleviate the deleterious process early on, it will make the surgery that happens to stabilize the joint that much more effective and result in less osteoarthritis downstream. We did gain a lot of insight into this process by comparing mice that are called super healers. And when mice that are super healers get joint injuries, they don't get osteoarthritis, whereas standard mice do. And trying to figure out what the difference is, what we've seen is that the super healers have an attenuated inflammatory process and compared to the ones that get osteoarthritis. So we think that it's important to have a little bit of inflammation to help clean up the joint, just like any kind of injury to your skin or anywhere else, but that it shouldn't go overboard. And by controlling that in the right way, we call the Goldilocks principle, trying to figure out just how much, just when, that we will be able to alleviate this early damage that seems, in our opinion, to make a really big impact in terms of a person's risk of osteoarthritis downstream from an injury.
Great, thank you. Continuing with kind of a similar thread, there's a question about whether or not there are any activities that worsen osteoarthritis, particularly in the hands, but really in any joints.
That's tricky,
so
certainly.
Sorry.
Yeah, go ahead.
I just have a couple of quick sentences. From a orthopedic perspective, the general rule is that if you have a damaged joint, high impact activities in general are not a good thing. That includes running. As long as you have a completely normal joint, those activities are actually good for your overall joint health. But in the moment where you have either diagnosed OA or you have had a joint injury, those activities may become detrimental to the future of the joint. That said, strength of your musculature, particularly around the hip and the knee joint, as well as flexibility, are keys for those injured joints not to progress to osteoarthritis faster. They will progress extremely fast if they start getting stiff. And that's where I can leave it on my part, I think.
Yeah, and I'll just add to that, specifically around the question of the hand. We prescribe grip protection measures. Tight gripping can exacerbate hand osteoarthritis. A group in the UK ascribes to specific finger strengthening exercises as a benefit, and that is very analogous to what Dr. Latterman just said about muscular strength for other joint OA being very important. We also tend to try to give individuals assistance in guiding their own therapy and activities by referring them to the 2-hour pain rule. The 2-hour pain rule is if you do something and it leads to discomfort that lasts for over 2 hours, then that means that it was too much or too long. And so that can be a good guiding principle for osteoarthritis of any kind. And the other guiding principle is if the next day after activities you feel like a truck ran over you, that also is an indicator, a signal from your body that you should follow. That means that you should modify in some way what you did to alleviate that, because it's usually a sign of having induced inflammation in the joints.
Great. I think we have time for one more question, and there's actually been several questions about joint replacements. So I'll summarize and just ask generally, how do you know it's time for a joint replacement? And then what questions should you ask about the prosthesis and about the surgery itself?
So my general recommendation is a joint replacement. There's three major aspects that you have to think about. One is, what is your age and activity level? B is, have you really tried everything else prior to making the decision that you want to go ahead with a joint replacement? And the third question is basically, what are the risks involved in your particular situation? Age is important because if you are in your 70s, you have a very different activity level than if you are in your 40s. And a joint replacement, particularly the knee or the hip joint, which is what most people usually talk about, although I saw that as a question about shoulder here too, those are very, very good and effective treatment options, but they have a limited lifetime. This is basically, you need to look at it like a tire change. You do not get a new knee back. You get a knee back that has somewhat limited functions, particularly when you're talking about a total knee replacement or a total hip replacement. And they have wear, which is higher than what a normal joint would normally have. A normal joint is designed to last 60, 70, 80 years. A joint replacement is designed to last between 10 and 15 years. So if you are 40, you will likely have 2 or 3 of these, and each one will become more difficult. If you're 70, you may or may not need a second one if everything goes well. The second question is, do not believe that a joint replacement is necessarily the end of all pain. We do know that particularly in young people, total joint replacements are not accepted that well. And if you truly, from a surgeon perspective, when we are looking at the joint and how it functions and whether it swells, etc., we like to slap ourselves on the back and say, well, they do fantastic. Well, unfortunately, this is not the same when you are asking the patients truly how they perceive their joint, because particularly younger people feel fairly impacted by the fact that a total joint replacement, particularly in the knee, does really not function like a normal knee. It is much more restrictive in the way you walk. It will change your gait, etc., and that can have other effects. And the third aspect is basically you have to look into what your overall health is, because a joint replacement is a very big surgery. So there is significant risk that can be associated with that has to take things into account, like infections, like loosening, like bone quality, other diseases such as diabetes, etc., play a role. A final point to make is basically there is certain situations where you can wait too long and then suddenly it becomes a big problem. And that is typically when you have significant loss of one central part of your joint. And then in the knee joint, for example, that is when it comes to alignment. That means if you are in a lot of bow-leggedness or a lot of knock-kneedness, if you let that go too far, then suddenly your straightforward total joint replacement may become very difficult to do and may have other implications such as potential for nerve damage, etc. So you need to have that looked at. And the other thing that in the shoulder, you have a rotator cuff that moves your shoulder around. If you lose that muscle, then your shoulder starts becoming osteoarthritic very quickly. And you have to watch it very carefully that it does not start to actually completely pop out of the joint, because if that happens, then it becomes very, very difficult, and then you have to do a specialty replacement whose runtime and lifetime is even shorter than that of a total shoulder replacement. So when you get to the point where you think, you know what, this is really getting bad, make sure that you're being looked at by a joint replacement specialist for a consultation, not necessarily to have it immediately replaced, but to talk about, does it make sense to do it now or not?
And I would just add to that, this is a really fascinating question highlighting the complementarity of thinking of orthopedists and rheumatologists. Because as rheumatologists, we're often asked this question and asked whether or not it's appropriate for the individual to get referred to orthopedics. And we have 3 other criteria that we tend to cite. And one is, so I'll add them because I think that they really add to what Dr. Latterman just said. One is sleep disturbance. And I found out only yesterday that the National Health Service in the UK has just passed the rule that the only way that you can get National Health Service to pay for your joint replacement in the UK is to have sleep disturbance. That's the one and only criteria that they'll accept. A second one is, does the individual feel grumpy all the time or have family members complained about a change in personality? And the third one is quality of life. If there are really things that the individual cannot do, they really want to do, and they find that that joint is now rate limiting, that would be another factor to consider as being possibly a motivation for going and talking to an orthopedist about the appropriateness of a joint replacement at the present time.
That's wonderful. Thank you so much. Oh, sorry. Go ahead, Dr. Latterman.
Yeah, I just wanted to say I agree, and all of these points are important to mention when you are talking to a specialist, because they may not ask that question, but that is information that is important.
Great. Well, I just want to thank you both so much for providing all of that wonderful information, and thank you as well to all of our participants for all of your questions. This was such a great discussion. We really appreciate each of you taking the time to contribute to our goal of advancing forward to find a cure for osteoarthritis. And we want to let you know that the next step for this project will be a meeting in Washington, D.C. on March 8th involving the FDA, the Arthritis Foundation, arthritis patients and researchers, and many other important stakeholders. So please watch your inboxes for additional information about how to participate in that meeting, either in person or virtually. And then lastly, in addition to contributing to the science of finding a cure, there are many other ways you can get engaged at the Arthritis Foundation. The upcoming Advocacy Summit is a great example of this. To learn more about the March 2017 Advocacy Summit, which will occur on the 6th and 7th of March, please go to www.arthritis.org. Thank you again, and enjoy the rest of your day.